So the first lecture, Dr. Cleary, unfortunately was held up because of weather in Chicago. So he will be here tomorrow. We have rescheduled this session. But we will start with Dr. Maithel. And I have the distinct pleasure of introducing Dr. Maithel, who he and I went to medical school together at the University of Chicago many, many moons ago. But he is currently, after graduating from Chicago, he did his surgical residency at the Beth Israel Deaconess Medical Center in Boston, and then did a surgical oncology and hepatobiliary surgery fellowship at Memorial Sloan Kettering. After New York, he went down to Emory, where he is now a professor of surgery and scientific director of the Emory Liver and Pancreas Cancer Center. And he will be talking to us about the surgical management of intrahepatic cholangiocarcinoma. Shishir, welcome.
Thank you very much. First, I would like to say it's an honor to be here, and thank you to Dr. Chen and Dr. Roca for inviting me to participate in this wonderful conference. So my task is just to talk about surgical approach to intrahepatic cholangiocarcinoma. And mainly, I will not be talking about the technical aspects of it. I do have a disclosure of Celgene is funding a trial for which I'm PI, which we'll talk about. But mostly I want to discuss the biological and the outcome implications of tumor characteristics that we look at on an everyday basis when we're assessing patients for resection, and really to look at those characteristics and what they mean and how do we decide when surgery is the best option and when should we look at other therapies in conjunction with surgery, such as liver-directed therapy and potentially preoperative chemotherapy, in order to determine the best clinical pathways for our patients. So this talk is specifically on intrahepatic cholangiocarcinoma. You can see that the incidence of cholangiocarcinoma is rising, shown in the light gray bars. So in order to understand the tumor characteristics that really portend how these patients do, let's take a tour down the evolution of staging. So we're currently in the 8th edition of staging, and if we go back to the 6th edition, you will see that the T stage was dependent on the number of tumors, whether there was vascular invasion, as well as the size of tumors. And then nodal metastases were designated a stage 3C in the 6th edition. Tim Pollack's group, who's now at Ohio State, looked at a SEER database of almost 600 patients, and they looked at just patients who had microscopically confirmed intrahepatic cholangio, particularly excluding extrahepatic cholangiocarcinoma. And when they looked at the different tumor characteristics and variables that were prognostic for survival, they could see that size actually did not portend any influence on survival, but actually multiple versus single lesions did, and vascular invasion did. So using these data, they proposed a new T-stage classification that excluded size from the staging. And you can see then this was basically informed if they applied that new T classification to that SEER database, you can see that the patients were very well stratified by T1, T2, and T3 disease based on the new proposed, which again excluded size. So that informed basically the 6th edition becoming the 7th edition. And you can see here now for T stage actually did not include size. And other things to point out, in terms of stage 2 disease, which is T2, which is multiple tumors, is only designated stage 2. We'll touch upon that in a second. And lymph node disease, when prior was stage 3, now was designated stage 4 disease because of the poor prognosis associated with lymph node positive disease for intrahepatic cholangiocarcinoma. So if we look at some of the data now in terms of how these patients do with these types of characteristics, size and multiple tumors and lymph nodes, first you look at a series from Memorial Sloan Kettering, starting with 240 patients. By the time you go through the 60% or 50% that are unresectable at presentation, and then another 30% that are found to be unresectable in the operating room, really only about 30% of patients with intrahepatic cholangiocarcinoma are actually surgical candidates. Now, if we look at size, keep in mind for the 7th edition staging system, size was not involved in the staging system, but you can still see that tumor size less than 5 centimeters does much better than tumor size greater than 5 centimeters on the left. And then the difference of solitary tumor versus multiple tumors. You can see that the difference in survival is quite extraordinary. However, multiple tumors was currently only designated a stage 2. These tumor characteristics do not work in isolation. You can see as size increases, there is an increased risk of multiple tumors, increased risk of lymph node metastases, and increased risk of vascular invasion as well as higher grade. So as the tumor gets bigger, it's more likely to have adverse pathologic characteristics. And how do these patients do? Well, we know that the risk of cholangiocarcinoma recurring after a curative intent resection is fairly high. Overall, about 2/3 of these patients will recur. And if you look at patients who have a single tumor, small tumors, and no lymph node metastases, the risk is lower, maybe 40%. But in patients who have high-risk pathologies, such as large tumors or multiple tumors or lymph node positivity, the recurrence is nearly 100%. And in terms of where they recur many times in the contralateral liver, so the side that's left in, or the future liver remnant. But a lot of them, or over half of them, are recurring extrahepatically in the lymph nodes in the peritoneum or even extra-abdominally. Again, here, the Pollock group looked at this again in size, and you can see again, even though size was not part of the staging system in the 7th edition of the AGCC, size in the blue greater than 5 centimeters portends a poor prognosis. And again, if you combine these, major vascular invasion, size, and lymph node involvement, and create a score, patients with a higher score, meaning having tumors that contain more of these characteristics, they have a lesser survival, shown in the gold and the green, compared to patients who have tumors that don't have any of these characteristics, shown in red. And the most common site, again, of recurrence is intrahepatic, i.e. in the contralateral liver, the part that was left behind. So in terms of multifocal, this is often a paradigm we see. Sometimes you'll see multiple tumors scattered throughout the liver in bilobar fashion, and sometimes we'll see the dominant lesion, maybe on the right side, with what we often refer to as satellites or moons. So the question is this multiple tumors or stage 2? Or I just told you that most of the tumors, the most common site of recurrence and metastases is in the liver, so should we look at this and say this is stage 4? This is very difficult, and this is often made as a decision on a patient-by-patient basis, but based on the data I just showed you, every time there are multiple tumors, it's always associated with higher recurrence and worse prognosis. So I think biologically, despite multiple tumors only being designated T2 or stage 2, I think this probably really acts biologically like stage 4 disease. Now, the importance of lymph node dissection is really, again, Tim Pollock has put a lot of work together in intrahepatic cholangiocarcinoma and looked at a large series over 30 years. It was a multinational series and found that only about 50% of patients were actually receiving a lymph node dissection at the time of resection for intrahepatic cholangiocarcinoma. And of those, about 1/3 were positive, but when positive, lymph node positivity had a very poor prognosis. In fact, the impact of vascular invasion you can see on the left in the dotted line. If someone has vascular invasion and lymph node negative disease, it portends a poor prognosis. But once the lymph nodes are positive on the curve on the right, you can see that the impact of vascular invasion goes away. Thus, once you're lymph node positive, whether or not you have vascular invasion makes no difference. And also, the impact of multiple tumors seems to be negated as well in the setting of node-positive disease. So harvesting the nodes may not necessarily be therapeutic, but it is definitely prognostic and helps to stage patients and also counsel patients in terms of their prognosis based on lymph node status. Now, there have been multiple nomograms that have been developed outside of the AGCC staging system that have looked to prognosticate in patients, and you can see in this one, again, size is part of it, despite it not being part of the AGCC 7th edition. And in this other one, there was also, this was actually developed by Pollock himself, who actually helped inform the 7th edition staging system, and even in his own nomogram, size was part of it. So the 8th edition then reincorporated size, and now you can see that the less than 5 centimeter and greater than 5 centimeter is divided between just a T1A and B. So there's not very a strong designation with size, but size came back in. You can see that T2 still is only stage 2, and T2 represents multiple tumors. And again, lymph node positive disease, despite all the poor prognosis associated with lymph node positive disease was downstage back to a stage 3B, when in the 7th edition, it was a stage 4. Now, when we have looked at comparisons of the 7th edition and the 8th edition, people have looked at these in large series, and they quote, the AJCC 8th edition staging system for ICC was largely comparable to the 7th edition version and did not provide a marked improvement in overall prognostic discrimination. So I think right now we know the different factors that portend prognosis, such as size and lymph node status and vascular invasion and number of tumors. However, I don't think we have the staging system correct. Now, it really comes down when you're looking at resectability. There's a technical resectability in terms of inflow, outflow, biliary drainage, and the size of the liver remnant. But biologically, perhaps more important, looking at the recurrence and survival of these tumors based on those factors that I've just delineated. So I think instead of just saying, well, this is resectable, I can take that out, we really need to think about, well, it's resectable, technically resectable, but it could be oncologically high risk. Should I take it out? And if I should take it out, when should I take it out? And should any other therapies be done prior to surgery? So what are the other options besides resection? Now, liver-directed therapy are one of these options. There's a whole session on liver-directed therapy, so I'm going to do this very briefly to focus on more of the chemotherapy. But transarterial chemoembolization is an option we can use, again, in well-selected patients. These are patients who are non-resectable, median overall survival approaching 2 years with TACE. Again, this was a very heterogeneous population, only 17 patients. But you can see, again, that patients with TACE compared to best supportive care, 13 months compared to 4 months, 11 months compared to 3 months in patients who have extrahepatic disease. So again, in well-selected patients, TACE is an option. In terms of, again, this is just the Hopkins series showing the same thing with the survivals ranging anywhere from 9 to 23. Yttrium 90 or radioembolization is another option. Again, this is the data from Northwestern. Looking at the importance of patient selection. So if you can see, if you just look at these Kaplan-Meier curves, the overall survival maybe being about 9 months, but you can see we heard about the peripheral versus infiltrative type of histology with the mass forming in blue doing better, patients with better performance status on the bottom left, and also patients with no extrahepatic disease. But these are all liver-directed therapies. This was a series from Emory that looked at the use of liver-directed therapy in patients who had received chemotherapy. And you can see from diagnosis, 62% 18-month survival, and from the time of use of yttrium 90, a 17% survival at 18 months, which is good, again, but well-selected patients who have actually seen chemotherapy. Whether or not you use one or the other, I think that probably doesn't really matter. I think it's more what your expertise are and what the institutional preference is. But some of the data would suggest that there's really no advantage to TACE versus Y90 or bland embolization versus chemoembolization. Now, hepatic arterial infusion therapy, this is something, as someone who trained at Memorial Sloan Kettering, this is something, it's impossible to give a surgical talk on the liver without at least mentioning this. This is the data from Memorial, looking at, again, at 34 patients, of which the majority were intrahepatic cholangiocarcinoma. These are patients who had no extrahepatic disease, good performance status. They did not actually get systemic chemotherapy with a median survival of almost 30 months. Difficult to replicate that. This was a study from the East looking at the same kind of hepatic arterial infusion therapy. Again, you can see that survival times of about 14 months, so maybe a half of what we see at Memorial. Not an uncommon situation where it's difficult to replicate the data that we see from pump therapy out of New York. And then Dr. Song will be talking a lot about stereotactic body radiation therapy, so I'll just briefly mention this. Again, very similar to the TACE and Y90 series. In well-selected patients, there is a reasonable median overall survival for patients non-resected. And very congratulations to the radiation oncologist for at least proposing this trial that was actually trying to look at the use of SBRT in the setting of non-resectable, non-metastatic intrahepatic cholangiocarcinoma in conjunction with chemotherapy. Unfortunately closed due to a lack of accrual, but again, at least they got the trial off the ground. So I'll focus the last 5 minutes on preoperative chemotherapy. All of the liver-directed therapies, again, are only focusing on the tumor itself. But as I mentioned, after resection, the majority of recurrences are happening in the contralateral liver or extrahepatically. So that liver-directed therapy, the TACE, Y90, SBRT, is not really doing anything for the potential micrometastatic disease that already may be present at the time when we're deciding whether to do an operation. So I think this is where we have to really start thinking about preoperative chemotherapy for resectable, oncologically high-risk intrahepatic cholangiocarcinoma. And I think this is the paradigm we follow for pancreas cancer now. We know that pancreas cancer is a systemic disease at diagnosis, and looking at those recurrence rates, for at least for oncologically high-risk intrahepatic cholangio, we should start thinking that there's probably presence of micrometastatic disease. So how can we treat this a little bit better? The advantage of chemotherapy is it's going to be treating the contralateral lobe and also the extrahepatic disease that may exist. So currently the standard is GemCis, and this is based on the ABCO2 data, as was covered, the GemCis versus Gem. So we're constantly trying to improve the systemic therapies. Now, we've talked a lot about the molecular profiling of patients and FGFR2 and IDH mutations, but the reality is those exist in only 15% or so of the patients with intrahepatic cholangiocarcinoma, and the other molecular potential actionable targets are even in less percentage of patients. So as we approach patients for resectable disease, if you say only 30% are resectable, and of those 30%, only maybe 10 or 15% are going to have the FGFR2 mutation or the IDH mutation, it becomes challenging to do large-scale studies in the preoperative setting for patients with resectable disease. So I think at least to start, probably starting with systemic chemotherapy may be a little bit more of a feasible option. So in an effort to really improve upon the GemCis platform, the Mayo and MD Anderson groups looked at the GAP regimen, which is GemCis and nab-paclitaxel. And this was in a single-arm phase 2 study of approximately 50 patients between those two institutions. And they saw that the median overall survival was 19 months. Compared to the 11 months, there was a good signal there. And this actually has led to the phase 3 randomized trial, which the PI is sitting in the audience, Dr. Schroff, which is going to be looking at GemCis Abraxane versus GemCis. Again, however, this is for advanced metastatic non-resectable disease. And I think one of the things that we often see, especially as a surgeon, we see all these drug trials are happening in patients with advanced metastatic disease. And we have to wait many years for those trials to report out before we start applying those therapies to patients with resectable disease, either in the preoperative or in the adjuvant setting. So this was kind of the instigation for this, and this is through, again, the power of this network and the power of groups like this and the ICRN that Dr. Javle talked about, and through the leadership of Stacy through the Cholangiocarcinoma Foundation. So Dr. Roca and I are leading this trial together, looking at a single-arm feasibility study of GemCis Abraxane for resectable but locally advanced, or we're calling oncologically high-risk intrahepatic cholangio. So all of those factors that I just went over in terms of increased size, multiple tumors, potential major vascular invasion that we can see on the imaging preoperatively, or in large lymph nodes that could be involved either by biopsy or by PET scan or just by size criteria. These are all patients that we were trying to enroll in a feasibility study using this regimen concurrently. Right now, the trial is open. We've already have 3 patients on. I think there's a 4th one waiting to go on soon. But we're trying to do this concurrently as this regimen is being tested for patients with metastatic disease on the large-scale National Cooperative Group study. And so by this, we're hoping to really try to study patients with resectable disease concurrently and in parallel as we develop these new therapies and regimens for patients with cholangiocarcinoma. Now, this is a feasibility study. So it's 34 patients, but if there's a signal here, these will hopefully lead to larger phase 2 randomized studies or even phase 3. And these are studies that's very difficult to do in the United States based on the incidence you saw, maybe 8,000 total cholangiocarcinoma in the US. And this is why this network of people here and this working and collaborating with you all, this is how we're going to get this done and do these preoperative therapy trials. We have to partner with our colleagues in the East, where you guys are the experts for this disease. You see it so much more than we do. So based on all of that and looking at the different characteristics, I think you can kind of, very similar to pancreas cancer, you can put patients in these categories. So if you look to the far left, if someone's clearly resectable and oncologically, if I dare say the word, low risk for cholangiocarcinoma, a small tumor, no lymph nodes enlarged, one tumor, those patients probably should go straight to surgery and then get adjuvant therapy, likely with capecitabine per the BILCAP trial. If patients are unresectable, either technically or completely biologically based on metastatic disease in the liver, then I think it's pretty simple. Then you have options of chemotherapy, maybe chemotherapy plus liver-directed therapy, or just liver-directed therapy, depending on the situation and the performance status of the patient. But really, the middle one is that we've been focusing on in the preoperative therapy trials, what we're calling borderline resectable or oncologically high risk. And these are the patients, like I mentioned, larger sized tumors, major vascular invasion, enlarged lymph nodes. These are the ones that I think we should do preoperative therapy. If we just do liver-directed therapy as a pre-op therapy, you're only focusing on the liver. There's really no attention to the potential micrometastatic disease that may exist. And now you're using that pre-op therapy more as a test of time to see if the patient will develop metastatic disease. But another option would be chemotherapy, or we should be entering trials or getting biopsies as we get better and better at biopsies and these targeted therapies. And I think we just need to really work toward preoperative therapy so we can learn more about these tumors on the specimen as well, looking at the response rates, and hopefully really to improve the outcome of patients, because these are the majority of patients that we're going to be operating on. They fall in this oncologically high-risk category. Thank you very much. I'd be happy to take any questions.
Excellent talk. Any questions for Dr. Maithel? Yes, in the back. Dr. Primrose.
If I have a patient with multiple tumors in contralateral lobes, those ones I usually never operate. Those ones I'll treat with systemic therapy and then maybe liver-directed therapy down the road, depending on how they respond. For the patient who has a dominant lesion but very small satellites next to it, and again, all amenable to a resection, maybe with a hemihepatectomy, those ones, again, I don't ever use surgery as first line. Usually right now I've been giving Gemcis for about 4 months to them, and then hopefully looking for a response, or at least looking for no progression, kind of looking as a test of time. I have done TACE to a couple patients as well, treating that patient, but I always wait a few months prior to resecting a patient with multiple tumors and satellite, but only are the ones who I would deem satellite nodules as opposed to a contralateral met in the contralateral lobe. But now we're trying to put them on trial, Gemcis and Raxane. So.